So talking about derived scores and what that means, one of the more common ones that we often think of naturally in the context of any kind of test and how to score it and then compare those scores are the percentile ranks, right? So the percentile rank is what reflects the percentage of scores that are at lower than an obtained test score. So for example, let's say a test result fell at the 75th percentile rank. It's higher than that obtained by 74% of the population. So in other words, the individual obtaining this test score scored higher than 74% of the individuals in the standardization group. And typically percentiles are reported as whole numbers, so that the highest percentile possible would be 99 and the lowest would be 1. And another way to think about percentile ranks is that they reflect the percentage of the area underneath the normal curve that is to the left of the given score. So T-scores are standard scores with a mean of 50 and a standard deviation of 10. Z-scores can be transformed into T-scores by simply multiplying the given Z-score by 10. The standard deviation of the distribution of a T-score is 10, and then adding 50 to that, which is the mean of the distribution of T-scores. So if the variable measured by a test is normally distributed, we would expect that 2/3 of the population would obtain scores between 40 and 60, and that's considered the normal range. And we would expect that 95% of the distribution lies within 2 standard deviations of the mean. And that is T-scores between 30 and 70, right? So scores that fall above 70 or below 30 would be considered unusually high or unusually low, as only 5% of the population obtains higher or lower scores. So deviation IQ scores are a standard score with a mean of 100 and a standard deviation of 15. Z-scores can also be transformed into deviation IQ scores, and they're done this by multiplying the given Z-score by 15, which is the standard deviation of the distribution of deviation IQ scores, and then adding 100 to that, which is the mean. So if the skills measured by an IQ test are normally distributed, we would expect that 2/3 of the population would have deviation IQs between 85 and 115. This is considered the normal range. And we would expect that 95% of the distribution lies within 2 standard deviations of the mean. And so scores that fall above 130 and below 70 are considered unusually high and unusually low. And so 70 is, for example, the cutoff for identifying an individual who meets criteria for a developmental disability. And scores that fall above 130 is considered gifted. The normal curve is a hypothetical distribution of scores that's widely used in tests. It's a symmetrical distribution of the scores with an equal number of scores that are above and below the midpoint. So given that the distribution of scores is symmetrical, the mean, median, and mode all fall at the same point. Since many measures like intelligence and achievement test scores assume that normal distribution, the concept of the normal curve is pretty important because if we divide the distribution up into standard deviations from the midpoint, a specific percentage of scores will lie under each part of the normal curve. STAY9, otherwise known as standard 9 scores, range from 1 to 9 with a mean of 5 and a standard deviation of 2. STEN, or standard 10 scores, range from 1 to 10. And in those cases, there's the mean of 5.5 and a standard deviation of 2. So STAY9 and STEN scores are used in different kinds of tests. IQ scores are also standardized. They have that mean, like we were talking about, of 100 and an SD, or standard deviation, of 15. Grade equivalent scores are norm-referenced developmental scores. They're most frequently reported for achievement tests. So they're the ones that compare an individual score to those of the norm group. And that is comprised of let's say, students attending the same grade in school as the person whose score is being reported. So for example, developmental scores can be expressed as 5.6 or 5.26 and interpreted as the average scores of 5th graders as the 6th month of 5th grade. So some grade equivalent scores are the mean score, whereas others are the median score. The technical manual for these kinds of tests indicate which measure of central tendency, in other words, the mean or the median, was used to determine grade equivalent scores reported in those instances. So you would refer to the specific tests manual to know which to utilize. But grade equivalent scores, as you know, are widely used in schools. However, they are pretty difficult to interpret, and so they're not used outside of schools as often. So when we are conducting psych tests, we use a statistic called a correlation coefficient to measure the strength of a correlation. And really, a correlation is simply the relationship between two or more variables. So a correlation coefficient can range between -1 to a +1. So a -1 is considered a perfect negative, and a +1 is considered a perfect positive. So a positive correlation then is a relationship between two variables in which both variables are moving in the same direction. So when one variable increases, as the other variable increases. And it's also a positive correlation if they're both decreasing together. So the key for positive correlation is are both changing in the same way, in the same direction. So if one variable decreases, then and the other variable decreases also, we see a positive correlation. So an example of a positive correlation would be height and weight, right? So taller people tend to be heavier and shorter people tend to be lighter. A negative correlation is simply the opposite of that. It's the relationship between two variables in which one increases and one decreases. So an example of a negative correlation would be like the height above sea level and temperature. So as you go higher in elevation, it gets colder, and vice versa. If you go lower in elevation, it gets warmer. A zero correlation simply means that there's no relationship between the two. So as far as we know, there's no relationship between how much a person likes elephants and whether they're good at roller skating. I mean, maybe there is, but we haven't found it yet. And so as far as we know, there's no correlation, right? So it's a zero correlation. So when it comes to test worthiness, there are 4 different types, and we'll dig into each of these individually. But in general, we look at the validity of the test. So is the test actually measuring what it's supposed to measure, what we're intending it for? Is that test reliable? As in, is it accurate and consistent in how it's measured? So if I reapply this test over and over again, am I going to get the same kind of scores or answers? Practicality, so is this even a practical test to use, right? So a super long test with a bunch of complex scoring methods is not going to be practical in an individual counseling session. So we look at the practicality. Is this something that can actually be used practically? And then we look at cross-cultural fairness. So has the test actually been shown to be fair across different cultures? Because as we know, the outcomes and results of a test are very much influenced by the cultural context with which they are given. So going more into each of these, when we look at test worthiness and validity, there are 3 main types that we're going to look at here. So the content validity is the extent to which a measure covers the construct of interest. So for example, if a psych researcher defines test anxiety as involving both the sympathetic nervous system activating and negative thoughts, then his measure of test anxiety should include items about both the nervous feelings or sympathetic nervous system activation and negative thoughts. Or consider that attitudes are usually defined as involving thoughts, feelings, and actions towards something. So by this definition, a person has a positive attitude toward exercise to the extent that he or she thinks positive thoughts about exercising, feels good about exercising, and then actually exercises. So to have good content validity, a measure of people's attitudes toward exercise would have to reflect all 3 of those aspects. So it would have to reflect the positive thoughts, the feeling good, and then the actually exercising. That's your content validity. So like face validity, which we'll talk about, content validity is not usually assessed quantitatively. So it's not usually something that you can put on a line graph. Right? Instead, it's assessed by simply checking the measurement method against the definition of construct. Criterion validity is the extent to which people's scores on a measure are correlated with other variables. So those variables are the criteria that one would expect them to be correlated with. So for example, maybe people's scores on a new measure of test anxiety, those should be negatively correlated with their performance on an important school test. So if it were found that people's scores were in fact negatively correlated with their exam performance, then this would be evidence that these scores really represent people's test anxiety. But if on the other hand, it was found out that people scored equally well on the exam regardless of their test anxiety scores, then this would make it would cast doubt on the validity of the measure. So a criterion can be any variable that you have reason to think should be correlated with the construct being measured. And there will usually be a lot of them. For example, you might expect test anxiety scores to be negatively correlated with exam performance and course grades, and then positively correlated with generalized anxiety disorder or blood pressure during the exam going up, right? So if a researcher developed a new measure of physical risk-taking, let's say, people's scores on this measure should be correlated with their participation in high-risk activities like snowboarding or rock climbing, the number of speeding tickets they've received, maybe the number of times they've had to go to the ER for injuries. So when the criterion is measured at the same time as the construct, criterion validity is referred to as concurrent validity. But when the criterion is measured at some point in the future, so after the construct's been measured, it's referred to as predictive validity because scores on the measure have predicted a future outcome. We don't know yet. A test has construct validity if it demonstrates an association or relationship between the test scores and the prediction of some sort of theoretical trait. So intelligence tests are a really standard example of measurement instruments that should have construct validity. So a valid intelligence test should be able to accurately measure the construct of intelligence rather than that of other characteristics like memory or education level or confidence. So construct validity looks at whether the test covers the full range of behaviors that make up the construct being measured. That procedure is to identify necessary tasks to perform a job, and in order to demonstrate the construct validity of a selective procedure, the behaviors demonstrated in the selection should be a representative sample of the behaviors of what we're testing. Face validity is perhaps the most straightforward. It's one of the most basic measures of validity. You're simply taking the validity of the test at face value by looking at whether it appears to measure the target variable. So on a measure of happiness, the test would be said to have face validity if it appeared to actually measure levels of happiness. Face validity only means that the test looks like it works. So it doesn't necessarily mean that the test has been proven to work. But if the measure seems to be valid at this point, then that would give you reason to investigate further in order to determine whether the test is valid and should be used in the future. So face validity, because it's the most basic and it's kind of indicating whether it even seems to be valid in the first place, is really the first step to really bother taking. There's no reason to dig into retest methods and things like that if the test just at face value doesn't even seem to be testing what we intended it to test. There are 4 general types of test reliability. And so reliability, again, refers to the consistency of the measure. So there's the test-retest reliability, which is the extent to which the construct that's being measured can be consistent across time. And if that's the case, then the scores should be consistent across time. So people generally identify IQ as pretty consistent regardless of age. So a person's age, even though they get older, their IQ adjusts according to their age and stays within the same kind of range. So a person who is highly intelligent today, you can expect them to be highly intelligent next week, next year, assuming that they didn't experience a significant traumatic brain injury or something like that. So assuming that everything's going well for that individual and there's not been any kind of external interference, any good measure of intelligence would produce roughly the same scores for that individual. Clearly, a measure that produces highly inconsistent scores over time can't be a very good measure of a construct that is supposed to be consistent. So assessing test-retest reliability really requires using the measure on a group of people at one time, and then using it again on the same group of people at a later time. And then you look at the test-retest correlation between the two sets of scores. And as you can imagine, it's really critical, of course, that the group is the same both times, because otherwise you can't fairly compare the two score sets. Another kind of reliability is internal consistency, which is the consistency of people's responses across the items on a multiple choice test or a multiple item measure in some way. So in these instances, all the items on a measurement should reflect the same underlying construct. So people's scores on those items should all be correlated with each other. So for example, on a self-esteem scale, people who agree that they are a person of worth should tend to agree that they have a number of good qualities. And if people's responses to the different items aren't correlated with each other, then it would no longer make sense to claim that they are all measuring the same underlying construct. This is particularly true for any kind of measure involving self-report measures. Like test-retest reliability, internal consistency can really only be assessed by collecting and analyzing the data. You need those scores to be able to compare. And one approach to doing this is to look at a split half correlation. This really involves splitting the items into two sets, such as the first and the second halves of the items of a test, or even if this is a test that's just numbered 1 through 10, you could split the items into two sets with the even numbers and then the odd numbered items as a second set. And then a score is computed for each set of items. And then you take the relationship between the two sets of scores and examine it. Internal consistency reliability really defines the consistency of the results delivered in a test. It ensures that the various items measuring the different constructs deliver consistent scores. And there are really two great examples of that. Don't need to go into them into detail. I think the text might. And so I would encourage you to maybe research it a little bit. But the Kruder-Richardson and the Cronbach's coefficient alpha are both really standard examples for internal consistency reliability. It is worth noting that the Kruder-Richardson test is a lot more complex and detailed and in-depth. And that, I mean, frankly, really brings us to practicality. So again, we want to know, is this a realistic test to give? Can we realistically give a bunch of ADHD young adolescents a test of multiple choice questions that is 4 pages long and extraordinarily detailed and involves different kinds of rating scales? Is that realistic? Is it realistic to give a test that requires being in a certain kind of environment when that environment isn't actually all that accessible to you? Other factors that we consider, of course, are cost. The time that it would take to administer it and how hard or easy it is to administer. It's always ideal when we're able to have other people help us administer a test if we're doing this. So is it something that you could easily hand off or delegate or share with other people and still provide the same kind of results? Or is it a really complicated test that takes a lot of expertise and skill set to be able to administer? And if that's the case, then that's the kind of test that is going to be reserved for a different kind of setting, like maybe a person is referred to a neuropsychologist for a neuropsychological assessment. And so in those instances, the neuropsychologist is going to consider, okay, I have this set aside time with this person. We're sitting here one-on-one. I'm going to be able to administer these in-depth scales and tests, whereas outside of that sort of a setting, maybe in like a community counseling center, it would be much less easy to administer those kinds of tests. Again, format of test is also important. The most obvious examples being written versus on the computer. So do you have access to a computer screen for the client to utilize? If the client can't see very well, or doesn't have the highest literacy skills, is the test still accessible to them? The readability of the test, do we understand how to interpret and use this test? And again, the ease of interpretation, how long is it going to take to score this to basically get our intended answer? So cross-cultural validity refers to the degree to which evidence and theory support the interpretations and uses of test scores for different cultural groups and comparisons across groups. So comparative inferences require equivalence of measurement and comparability of scores when tests are administered in different languages, or when students from different cultural groups take tests in the same language. So you want cross-cultural validity, because cross-cultural validity and comparability issues are particularly relevant to assessments that have more complicated measurement points, that are particularly complex constructs in multicultural and multilingual contexts. So international assessments or assessments in countries with culturally diverse populations need to really have significant cross-cultural validity. So kind of a more concrete example of this is if we look at the nature and frequency of access to cultural practices outside of school, we know that can affect students' understanding of the items on an assessment and will then affect their performance on it. So for example, let's look at some students that are in a school in Canada, and the students who attend the French schools as linguistic minority students in Ontario, where English is, of course, the most dominant societal language, let's say they consistently perform worse in mathematics, reading, and science than French students in Quebec, where French is the dominant language. So similar performance trends have been observed for other ethnic, racial, and linguistic minority groups in other countries. And in those different instances, there are likely multiple factors contributing to those patterns. But ultimately, the contribution of the student's social and cultural context, it needs to be considered as important factors for learning and assessment outcomes. Earlier in part one of this week's lecture, I talked a bit about assessments and what a complete assessment report looks like. And so even when we are not doing like a biopsychosocial assessment that you may be most familiar with, but are actually conducting maybe a series of psychological tests and then writing a report about the outcome of those tests, it still requires a basic assessment report that generally includes a bit of the same information. There's always going to be the basic demographics about the client. There's always the information about reason for referral and who referred them. And then there will be other relevant information. And it's going to vary depending on what kind of an assessment report you're pursuing. A very complete biopsychosocial assessment report, for example, is going to address medical information, mental status exams, all of our test results, the diagnosis. There's going to be recommendations and the clinical summary and prognosis. But the assessment report, it is worth noting, will really vary in length depending on what kind of assessment report you are writing and what the intended outcome is. Some are really, really long, as you can imagine. If you are familiar with the ASAM criteria for substance use disorders, and ASAM assessments are quite lengthy because you are breaking the client's information down into 6 different dimensions. And so in each dimension is pretty long in and of itself. So at the end, by the time you've completed a full ASAM assessment, it's several pages long. On the other hand, maybe a more standard comprehensive mental health assessment will be a few pages in length comparatively. A few things that, I can go off on large tangents about language used in clinical documentation. Clinical documentation is honestly one of my very favorite topics. And we will definitely get into this a bit more as the weeks go on. I think something that's really important to be mindful about is that at the end of the day, all of the services that we are providing clients, including tests, are intended for the client. It's for the client's benefit. And so if that's the case, if we are providing genuinely person-centered treatment, then the language that we use should even be client-friendly. It is so easy to overuse clinical jargon in speech, especially if we're discussing the results of a clinical test. It's so easy to fall into patterns of just becoming much too clinical in our speech. That takes the human out of the client and also makes the information less accessible to the client. If you were to give the client a copy of their assessment, would they understand and agree with what you wrote? And so that's really important. And similarly, again, being person-centered means that we have to be focusing on the person and who this person is, and allowing the test results and this different information to paint a picture of who that person is, rather than just being results on their own that we're looking at. And at the same time, we have to look at those results. We can't just solely look at this person and not allow test results and different information that we collected to factor in our overarching clinical conclusion. And then there are just some really critical elements of writing a good assessment report. It needs to be organized. Most agencies have some standard forms that you have to utilize, and those forms have been developed according to the Oregon Administrative Rules, whoever your agency's accrediting body, like the Joint Commission or CARF. There are these different entities that will often kind of dictate the structure of the assessment that you've completed to ensure that you're covering all these different elements that have been proven to be the most important and critical for adequate service. So if you follow those forms, then you're much more guaranteed to have a decent organization. But regardless, whatever kind of form you're utilizing, you need to be able to organize your thoughts decently. This is where just basic core writing skills really come into play. You need to have decent writing skills when writing an assessment report. And you have to kind of take an angle, take a position, be honest about your perspective. Something that I encounter with a lot of newer counselors is that they feel really reluctant or hesitant to place a conclusion on the client. And that's really valid. And I always really appreciate a person who's taking it so seriously that they don't want to put a label on a client because they recognize the weight of that label. That's where we then make sure that we're being very clear that our outcomes are based on the information that we received, and that these outcomes are our interpretation. So we have what we call clinical judgment, and we're using that clinical judgment to the best of our abilities to interpret the results of our assessment and our various tests. And it's going to be affected, of course, by the information that we received. And that information may change over time. We may not know that we're missing some significant information. We may have much more information than a previous assessor had when they completed one. And I am a big fan of, in assessments, and I'll share a couple of redacted examples in the future for you to see some different kinds of language that you could utilize in discussing the outcomes of a test. I'm a big fan of being really exploratory in my write-ups of diagnosis in particular. I am a big fan of indicating which diagnoses I am suggesting that we rule out, that maybe previously were stuck onto this client, and in my opinion, inappropriately so. I will also indicate that maybe these are very much provisional diagnoses, or maybe that this is a historical diagnosis. I will also always include in that section recommendations for further evaluation. So maybe like, I can confidently say that this person meets diagnostic criteria for PTSD. I am not so confident in this historical diagnosis of bipolar disorder. And I would argue that maybe they more accurately meet criteria for cyclothymic disorder. So for now, I'm going to say let's say, diagnose the person with PTSD and cyclothymic disorder, and then say that replacing that disorder with a bipolar diagnosis would require further evaluation or more information. So again, you want to be fair and person-centered and really thoughtful and respectful in your approach. And that also kind of goes into the multicultural issue and the social justice focus. It's really important that we are using our assessment procedures appropriately and being cautious about how that is applied. It's nearly possible to ever provide a standardized test that doesn't have some sort of cultural bias. It just often does. It's so hard for it not to, because we are developing those tests from our own cultural lenses, and then we are interpreting those tests based on a cultural norm. And so so then we have to be mindful about that and aware of it, and make sure that the individuals that we are applying those cultural standards to are a member of that culture, or that standard is still an adequate representation of who this person is. And so there are a lot of standards and ethical codes that have been developed to help us with this. We should know when a test shouldn't be used due to bias, understand the cultural bias inherent in tests, and know what to do with test results when a test doesn't predict well for a minority individual. And so there are standards for effective use of assessment instruments. And there's a whole set of ethical standards in the Association for Assessment and Counseling's standards for multicultural assessment. There's the Code of Fair Testing in Education that addresses all of the different multicultural issues that you have to take into consideration when providing a student a test in the school setting. And then we have the ACA Code of Ethics that at the end of the day, I know it's lengthy and quite the read, but it's worth it. There are a lot of ethical, professional, and legal issues that we do want to be mindful of. Some of them are pretty straightforward, and a lot of them do have to do with HIPAA. So the proper release of test results really comes back to, do we have the client's informed consent to release these test results, and who are we releasing those test results to? According to HIPAA, we cannot release any kind of protected health information about a client to an outside entity without that client's express written consent. And so if the client has provided us written consent, like for example in the form of a signed release of information form, then we could release those test results to the person that the client identified as being appropriate. There are also, again, ethical issues around selecting the tests, making sure that it's something that's fair and valid for that person, and making sure that it's within our own scope of practice. And the same comes into play with administering, scoring, and interpreting that test. We need to make sure that we are not utilizing tools without either appropriate knowledge and training, or under direct supervision of somebody that has that appropriate knowledge and training. And if we are conducting these tests with a limited scope of practice under the supervision of someone else, then we need to be readily utilizing that supervision. Keeping tests secure is really critical. This again falls under HIPAA. So if it's a physical paper record, it must be kept locked whenever it's not being used, or basically manned by you in the moment. So if you're walking away from test results, then they have to be secured by being locked in a container. If you're transporting any kind of protected health information, it has to be transported in a double locking container. I think you've already taken an ethics course. Maybe not, I'm not sure what order some of these courses have come up for you, but this is something that does get addressed very much in ethics. But you'll want to apply those core concepts like HIPAA to what you're learning about in here, about tests and psychological assessments. Something also to keep in mind in terms of professional issues is that a lot of computer-driven assessment reports can be really good, but they are also really computerized and kind of robotic. And so you really want to make sure that you're going in and editing and providing maybe a clinical justification or summary at the end of the report that kind of puts the human back in the test and also applies your own clinical judgment and interpretation and isn't just solely a bunch of numbers spit out by a computer. There are a lot of legal entities and acts and titles and amendments that are in place to ensure that we are taking the right steps to be legal and ethical with our assessments. And so these next couple of screens are simply a list of different legal acts that I would encourage you to spend some time looking into. And again, frankly, the ones that you should be most familiar with right now are becoming very familiar with HIPAA, also become very familiar with the Freedom of Information Act, as in the right to access federal records, including your test records. Other acts as well, the Carl Perkins Act, Civil Rights Act. Do take a look at these, become familiar with them in your reading, and reach out to me if you have any questions.